Sir, you are live. Please start.
Yeah. A very good evening to all of you, respected doctors. It's indeed my pleasure and privilege to welcome you all for a very interesting webinar today on topic need of triple drug combination in hypertension in current COVID situation. And for this topic, we have two eminent faculties with us. Today's program will be moderated by Dr. P.KHazra, sir. I'll briefly introduce Prakash, sir. Sir is a head in Department of Cardiology and is a director of Cardiac Cath Lab at AMRI Hospitals, Dhakuria in Kolkata. Sir is a teacher and trainer in national and international platform. Sir is invited as a faculty to many national and international conferences. In his vast working experience, Sir has done primary PCI and angioplasty in more than 7,000 patients. And Sir is the first implanter of TFO closure device in Eastern India. So it's our privilege that today we have P.KHazra, sir, who will be moderating tomorrow's webinar. And as a speaker, we have Dr. Ayan, sir. Sir is a consultant interventional cardiologist and lead in heart failure services at NH-RTICS Hospital, Kolkata. Sir is an interventional cardiologist and heart failure specialist. He is an avid researcher. He has more than 30 publications in index journals. He has written chapters in textbook and editorials also. Dr. Ayan sir is invited as a faculty to national and international conferences, and he has represented India at the APSC Leadership Summit in 2019. And a special interests are heart failure, cardiac imaging, intravascular imaging, and structural heart disease. So with this brief introduction, I hand over the session to our today's moderator, Dr. P.KHazra, sir. Sir, please.
I welcome everyone to this beautiful symposium, and I'm sure everybody is doing fine from their health point of view. Now we have very, very elegant, and he is one of my favorite speaker in Calcutta, Dr. Ayan, and I can see a bright future in him as an intervention cardiologist. So these are the people actually who will take us to the next level of cardiovascular care in the country. And I know that we are talking about hypertension today, and we'll be talking on FDC, which is actually getting more and more evidence and momentum in the current anti-hypertensive regime. You know, this atherosclerosis, hypertension, diabetes, cancer, everything was there thousands and thousands of years ago. And we have mummy CT scan evidence that in mummies, which has been kept from a museum, and they have done CT scan published in Lancet, we could see the effect of hypertension on aorta, large aorta, calcification, etc., but we do not have any hard evidence of fossiliary evidence of hypertension in the past. In the present form, we are seeing different consequences of hypertension like stroke, heart failure, renal disease, etc. Now, there are different guidelines, and with time, there is no alignment of the guidelines. The threshold is coming down, especially in India. We have a lot of barriers in prescribing drugs, access to the medicines, compliance, which is very important, and sometimes is non-affordable. It's a drug which is meant for majority of people like Indians and Africans. It should be simple, it should be affordable and easily available. And all these can be achieved with 3 drugs in 1 pill or 2 drugs in 1 pill, rather than 2 drugs in 2 pills. So with this introduction, I will request Dr. Ayan to go through the presentations. At the end of the presentations, we'll take up some questions, burning questions. And I will also brief later on what are the newer theories of hypertension, like epigenetics, air pollutions, bone marrow theories, device theory, etc. Plus any other new development. First, let us focus on the topic, and I'll hand over the session to Dr. Ayan. Ayan, please.
Thank you, sir. Thank you for those encouraging words. What I think the host of this webinar really missed out is that sir is also one of the only proctors of the leadless pacemaker, not just in Calcutta but in India, and he has the highest number to his name. And he has always been one of our greatest, heroes, as far as we look up to him for all new interventions, for doing a lot of stuff which makes cardiology so interesting. So I will not take your time any further. I hope all of you all are doing well in this pandemic situation, and I will go directly to my slides. So today's topic is going to be about combination therapy in hypertension. I think you already know who I am. So this is an editorial as to why hypertension has become India's silent killer. So this is probably,
While
I
we
mean,
can't see
is
your slide, Ayan, hang on, we can't see your slides.
so you can't sleep. Hold on a sec. So I think I know why. Just give me 2 minutes. I think I stopped sharing my screen. That's why.
Yeah.
Let me just share my screen once more. Yeah. Can you
Fantastic.
see my?
Yes,
Yeah.
yes, go ahead, go ahead.
Okay, so it is of need of combination therapy in hypertension. So the last 50 days, 49 days to be precise, of lockdown has taught us very important lessons as far as treating cardiology goes. We've had to deal with very unique situations, especially when dealing with patients on telemedicine, elderly patients, patients having problems at home, unavailability of medicine sometimes due to supply chain problems, logistics, etc. So it's been difficult times, and we've had to rely on combinations to actually sort things out. So which is why this need for combination therapy during these difficult times. So just to give a brief background, hypertension happens to lead to almost 9.4 million deaths each year globally. And this is probably more than what is because of tuberculosis, AIDS, or just plain maybe diabetes. And if you know, it also is responsible for more than 50% of the strokes. So around 57% of all strokes, and that is a lot. So as you can see, and in our country, as you know, as sir was telling, atherosclerosis hits our population almost a decade earlier than maybe Caucasian populations, which is why it is all the more so necessary that all these factors which make a coronary artery disease progress, like hypertension, diabetes, OSA, etc., needs to be controlled so well. So I think the definitions or numbers, as we know, we are all familiar with. So you have two different, I think we are already going towards a format where we want to diagnose hypertension earlier, and we want to institute therapy earlier so that these devastating complications can be actually prevented. So the number is that almost more than 50% of the patients who are hypertensive in India are uncontrolled, and that is for various reasons. So as you see from this slide, in patients who are treated uncontrolled hypertensive, the chances of CV mortality is almost 74% higher. I mean, that is a hugely significant gap. And I think I don't need to tell you that most of these patients have end organ damage in the form of a stroke, retinopathy, coronary artery disease, peripheral artery disease, or kidney. So giving you a small insight from my OPD, 55-year-old male married IT employee. And these are the type of patients who probably do benefit from these kind of combination drugs. So typically pre-diabetic, less exercise, overweight, very odd working hours. And that is one of the reasons why he doesn't take his drugs at normal times. So hence the poor adherence. He has shortness of breath after climbing 2 flights of stairs. He was on a dose of telmisartan 40 in the night and amlodipine 5 milligrams with mild pedal edema. BP still hovering about 150 and a diastolic of 100, which explains the amount of shortness of breath. And this is probably the kind of patients which we see who are more prone for cardiovascular disease. So if you look at this, amongst the factors that are responsible for uncontrolled hypertension, we would like to specifically talk about non-adherence, which is quite common in certain cases because of financial reasons, because of polypharmacy, because of just plain societal reasons, because of other issues, because it affects lifestyle, as well as underuse of drug combination strategies. So there are a lot of physicians who practice monotherapy, and they try to just increase doses of single drugs that in many cases does not result in controlling of hypertension, but rather results in all the side effects from that drug. So how did the story from fat to fit happen for this 55-year-old gentleman? So it generally motivation helped. We chalked out a diet plan. He lost some weight, and we gave him the benefit of a triple drug combination like the telmisartan 40, amlodipine 5 with the CTD of 12.5. He had beautifully controlled pressures, and he's doing very well. And he's also happy to take just a single tablet in a day. So why hypertensive patients do not adhere? So as I said, we are looking at things like polypharmacy. It is, of course, the patient's attitude towards hypertension and drugs. It is sometimes because of physician inertia, as well as the fact that we have very busy OPDs, and sometimes we are not able to explain to our patients the necessary importance of controlling things like hypertension. And of course, you have to understand that hypertension, despite being well controlled, its benefits are not as palpable, maybe as angina. So you look at the vicious cycle. So uncontrolled blood pressure, you increase doses, it increases adverse events that results in further non-adherence to therapy, further uncontrolled blood pressure, and you have worsening of CV events. So as we said that there is some amount of clinical inertia, and of course there are other factors which contribute to clinical inertia that includes lack of knowledge, lack of guidelines, clinician's own judgment. We believe in a lot of anecdotal evidence. So we understand that 75% of hypertensive patients require a combination therapy to reduce blood pressure. So monotherapy generally should be non-existent unless and until we are talking about really very low to normal baseline blood pressures. So benefits of combination therapy. So combination therapy, the idea is so directly pointed out towards the very beginning of the talk. We are not talking about combining drugs. Combining drugs has already been happening over the last 4 decades. We are actually talking about the technology which certain companies bring forth to us, whereby they are combining 3 drugs in one pill, and therefore that itself increases adherence. So of course, this unique combination of an ARB, a calcium channel blocker, and a diuretic seems extremely beneficial because it targets various methodologies of or various causative factors of hypertension, and it is also effective in the way that it takes care of a partial part of diastolic hypertension too, and it results in LV remodeling, as well as it benefits in certain subsets of cardiovascular diseases like diabetics, heart failure, etc. So of course, as I told you, there's a complementary mechanism of action. So we are looking at both the diuretic ARB and the CCB ARB. So it kind of is complementary in its action because it takes care of each other's side effects. Of course, we've had multiple meta-analyses and trials which tells you that when you start combination therapy, early on, it basically results in better BP control compared to just single monotherapy, irrespective of the drug class. And of course, these kind of patients, they tend to be well BP controlled. So once your BP is better controlled, your chances of having CV events actually reduces. It is something that we have seen very commonly in a trial known as the SPRINT trial, which was published, I think, in 2018, if I'm not wrong. So if you look at this, so better CV reduction. So if you do start and continuing antihypertensive therapy, which means good adherence, results in a massive 26% CV risk reduction compared to just initiating with monotherapy. So it is, of course, an ideal choice, as I told you, in patients because we happen to be the diabetic capital of the world. So we have large amounts of patients who are on diabetes, and because of the early onset of coronary artery disease, early MIs, late presentations, a lot of heart failure is also present amongst the cardiovascular disease spectrum that we see on a daily basis, which is why it is all the more essential that these patients have a very tight BP control. What as physicians we often initially miss in the clinical practice is that instead of just harboring on more newer therapies like ARNIs, etc., sometimes essentially controlling your blood pressure well with combination therapy actually probably would give you the same benefit, but it is often less utilized, which is why we stress on optimal dosing of medicines which are used in heart failure. So if you look at the guideline recommendations over the years, so something from the Indian guidelines in 2013 to the AC guidelines in 2018, So an initial therapy of ACE inhibitor or an ARB plus a CCB is a standard of care as far as hypertension goes. And I think all the cardiologists who are probably listening to today's webinars or physicians, I think you would all agree or concur with me on the same aspect that all of us mostly see that these patients who are generally put either on ACE, ARB plus a calcium channel blocker, they do very well as far as BP control is concerned. And of course, it doesn't stop us from saying that we've had 101 trials, which have all showed that when you're using multiple combination of antihypertensive agents with different mechanism of actions, it results in better BP control. So the idea is that if you have monotherapy, 75% of your hypertension patients will still have uncontrolled BP. Now, if you have combination, you would still probably have a 25% to treat. And it is this 25 patients that I think we would be talking about. And today's topic is with the triple drug pill, that is chlorthalidone, telmisartan, and amlodipine, which very nicely they put it known as CTD TAM. So it is interesting to know that if you look at across the board, they have 5 milligrams of amlodipine, which is constant, and you can play around with the 40 milligrams of telmisartan and chlorthalidone of 6.25 and 12.5, which gives you a lot of options to actually titrate to your patient. Of course, as you can look at the pharmacodynamic rationale, it is very well established because you have an amlodipine on board, telmisartan, which works on 82, chlorthalidone, which is a diuretic, should actually take care of early diastolic dysfunction also. It will give you better symptom relief as well as better BP control. So the efficacy of triple drug combination, of course, so I think when I was a cardiology registrar, I have heard that refractory hypertension typically used to be diagnosed as 3 drugs plus addition of a diuretic. What we realized is that over the ages, that diastolic heart failure actually comprises almost 50% of all heart failure patients. And diastolic heart failure, unfortunately, despite all the drugs we have in our armamentarium, it actually, one of the best drugs which actually really work is diuretics, and low dose diuretics really work in diastolic heart failure patients. So most of these patients who have concomitant either OSAs or diabetes or hypertension, there's some amount of diastolic dysfunction with increased LA pressures, which always benefits from a small dose of diuretics. So as you can see in this slide, so you have better SBP, systolic and diastolic reductions, and more number of patients on triple drug combinations actually have achieved the target BP. So I think you would have heard of this. It's this forum known as Resolve to Save Lives, which actually plans to save 100 million lives from cardiovascular diseases and to prevent epidemics. And in the background of this Resolve, we saw a trial known as the Triumph trial, which tested the triple drug polypill in Sri Lanka. And of course, it was presented in the ACC 2018. It is funded by the Australian National Health and Medical Research Council, and it compared the triple pill versus usual care. So if you look at this, so initially, this initial study was initially started with telmisartan, amlodipine, and hydrochlorothiazide as a diuretic, but with the addition of the sprint results, I think it resulted in change of protocol, and they decided to go for the CTD compared to the hydrochlorothiazide, and I think that is what has resulted in this combination of CTD TAM. So the trial design is very simple: 700 patients divided in 2 arms, almost equal, 350, 350. One was on usual BP lowering medications, the others and was started on a triple drug fixed dose combination. And then there was the usual BP lowering medications, which of course has raised some eyebrows, and they remained on usual therapy. So we had an established standard of care in Sri Lanka, and against that we used an early on triple drug fixed drug combination. So if you look at the results, basically the results or the end point of the study was in order to see how quickly target BP was achieved. And they looked at it at 6 weeks, 12 weeks, and at 6 months. And if you look at it from this slide, so in the triple drug combination group, close to 70% of the patients had achieved their target BP at 6 months, which was almost 14% higher compared to that of the usual care group. And of course, if you look at it at 6 weeks and 12 weeks, so which means by 12 weeks, which is roughly 3 months, which is generally the standard follow-up we have in our patients, almost 72% of the triple drug combination had achieved their blood pressure targets. What is more interesting in the subgroup analysis is that diabetic patients who had a blood pressure of more than 148 by 85, those patients seem to benefit more. I think that is not something which we are surprised at, because the combination of an ARB and a calcium channel blocker is a very unique combination, because on one side the ARB is going to be renoprotective, and on the other side you have a calcium channel blocker which is going to be resulting in reduced LVH. So the positioning of this unique molecule is that typical BP, which is uncontrolled on dual therapy, patients who have other comorbidities like diabetes with high CV risk, means Framingham scores greater than risk scores more than 15%, as well as BPs greater than 150 by 90 or on escalation therapy. These are directly patients who should be given this single pill. Remember, it's a single pill with 3 drugs in it, very uniquely positioned in the market, and it is definitely something that we need to understand. So, summary and conclusion, we need to understand that reducing polypharmacy increases adherence. Hence, that results in better BP control. So, the triple drug combination of an ARB, a CCB, and a CTD is very ideal. It's targeting all multiple pathways, which causes hypertension, typically suited to the Indian scenario where you have a lot of hypertensives, a lot of diabetics, and of course, you have a lot of elderly also. Remember, it is, apart from being cost effective, as Dr. Hajra was saying, that these 3 drugs, if taken separately, is going to be very costly. But if you were to combine them into a single pill, I think it becomes extremely economical to the patient. And what my elderly patients really love about this drug is that the single day dosing, and they find it extremely attractive. So, and multiple combinations of ARB and CTD gives the physicians more options to titrate therapy. Of course, we have one single challenge, and that would be changing physician prescription behavior. That is something that I think only the drug companies, they have to reach out to your physicians, and you have to tell them that, okay, I mean, this is how things have been, and this is how patients are likely to benefit. Thank you so much.
Thank you, Ayan, and
Thank you, sir.
excellent presentation. So what I can understand that this combination, as Ayan has rightly mentioned, is easily available, attractive, once in a day, which can go in 3 or 4 different factorial forms. Like you can go from low, low, low of 3 drugs. You can go from high, high, high of 3 drugs. You can go from high, low, low, or high, high, and low. There are different combinations of these 3 drugs. Now, why not? You have to understand that why amlodipine is there, why clothalidone is there, why ARBs are there. Why not beta blocker? So beta blocker is not there in the combination, though we have some beta blocker plus diuretic, beta blocker plus amlodipine. But once you combine amlodipine with diuretic, there is high chance of hypokalemia. So you are respecting the potassium. And ACE inhibitor, why ACE inhibitor is not there? Because obviously in Africans you have angioedema, you have cough, etc., etc. So side effects will be definitely less. And the reduction of blood pressure in Indian subjects, from our experience, is very good with amlodipine.
Yes,
You
sir.
cannot call anybody resistant hypertensions or difficult to control hypertensions until unless you use 2 drugs. Though the definition includes 3 drugs, I would say amlodipine and hydrochlorothiazide or chlorothiazide has to be there, and it can go up to 25 milligram chlorothiazide or 10 milligram amlodipine. So this FDC twice in a day you can go. And another advantage, I would say, as you were rightly mentioning, the diabetes. Many of these Indians, they actually develop diabetes, and they do not know when they do develop diabetes. By the time they don't know they are diabetic, their kidney is having some kind of albuminuria, proteinuria. They have progression of atherosclerosis. They have some evidence of nephropathy and some evidence of left ventricular hypertrophy, which can be prevented or regressed, as Ryan has rightly mentioned, by early institution of this FDC. So these FDC fixed drug combinations, there is enough data now. European Society of Cardiology last year, they have presented that if you go by high, 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 all 3 high, you should be careful about the hypertension, but you get the maximum benefit as the study is mentioned. With that note, if you have any questions, we will be glad to answer. The question will be directed to Ayan first, then I'll. So in this format, you can see. Can somebody from the admin read out the question to Ayan?
Sachin sir, do you have the admin panel open with you?
Yeah. So tell me, Ayan, I mean, before we go to discussion, why not beta blocker in the combination? Why? Tell the participant why amlodipine, diuretic, inhibitor.
I mean, although I mean, of course, you leave apart the evidence part of it. Beta blockers basically is not the first choice of drug as far as hypertension is concerned. I think it would be a better kind of drug when we are talking about hypertension in the background of, let's say, a patient with chronic stable angina, or let's say with heart failure, where we need rate control is more important to us. And moreover, if we are targeting younger populations, I think beta blocker is not the best drug of choice. Because it has its own side effects which are quite annoying to the younger population. It probably is not as bad to the elderly, but for the younger population, beta blocker is not the best choice of drug. So as you correctly said, the Indian population responds very well to combinations of calcium channel blockers and ACE or ARBs, preferably ARBs, I would say.
Right. Why hydrochlorothiazide is not there? Why clothalidone is there in the combination?
I think that is based out of the SPRINT data, sir.
Yes.
So if you look at the SPRINT data, I think the SPRINT basically wanted to see in those patients where you actively targeted a BP of less than 120/80,
Right.
especially with a clothalidone based combination, they saw that there was significant CV benefits. And as I said, that probably the idea behind the data is again that most of these patients have some amount of diastolic dysfunction, which actually works, I mean, is very well treated with a low dose diuretic.
Right. If you want to add a fourth drug in a uncontrolled hypertension on the top of when the choice is exhausted with FDC, what will be your next drug?
Well, that would depend on the age of the patient and the comorbidities that the patients have. I would, if the age of the patient is on the elderly side, I would probably go in for an alpha blocker, maybe one of the minipress XL group of drugs, or or in other patients, I would probably still hang on to up titration of the doses, go up to optimal doses in these kind of drugs, because I think the fixed drug combination gives us the option of going up to 80 of telmisartan, 5 milligrams of amlodipine, and 12.5 of CTD, which generally works in most patients.
Okay. So somebody who is diabetic and he is on full dose of FDC twice in a day, CTD TAM, and still BP is not controlled, would you consider SGLT2 as a fourth drug?
SGLT2, I believe, is not predominantly poised as an antihypertensive drug per se, but of course, given its overall pleiotropic effects, it wouldn't be a bad option because it would take care of your weight. It could reduce, it has an osmotic diuretic benefit, which would add to the diuretic benefit of the hydrochlorothiazide. But of course, I would like to probably, I mean, especially if it's a diabetic patient, it's not a bad option, especially if he's obese.
Okay. So how do you place MRA on the top of CTD TAM?
So I definitely, if these kind of patients after 3 drugs, if they generally don't, there is always a question of hyperaldosteronism, which definitely is addressed by an MRA. It is one of the commonest causes of refractory hypertension, and I do find it very useful in our practice.
Okay, so there is.
But it's just that potassium has to be checked very often because you have an ARB as well as a aldactone on board, or a spironolactone.
If you take care of potassium hypertension or dietary advice is very important, as I was mentioning that potassium has to be respected, both hypokalemia and hyperkalemia. It's a U-shaped curve. If you produce hypokalemia, that is also bad, and if you produce hyperkalemia, that is also very bad. A patient with the HepA, hypertensive HepA,
Yes, sir.
and what are the drugs? Would you still consider this FDC first, or would you go in a different way?
I would still consider this FDC first, and if they still don't respond, I would still put an aldactone, because I think from the top cat studies, the MRAs are one of the drugs which has shown some benefit in the HFpEF population. And even after that, as I said, we could probably look at the SGLT2s. The SGLT2 would be my next preference of drug.
Excellent. Now there is a recent unveiling of RDN therapy, Medtronic RDN therapy for
Right, sir.
uncontrolled hypertension. So would
Mhm.
you still be skeptic in 2020 with RDN, or you are waiting for more data? What's your
So
view?
my personal experience with the therapy is very little, but as far as I understand, with the development of technology, it sounds more logical to employ that technology and see whether it benefits or not. I'm not somebody who basically shies away from new technology, but of course I think the data is not foolproof yet, but definitely there is scope for it.
Okay. So in the COVID situation, people have apprehension, the obvious question in every platform. People ask the same question: whether you will withdraw ARBs in patients who have COVID-19, will continue, or you go for will not initiate ARB or ACE inhibitor in patient who is suffering from hypertension, diabetes, and COVID-19, who are either symptomatic or becoming hypertensive for the first time to you.
As per the last directive from the EHC, I think ARBs definitely can be given. But as far as ACE inhibitors are concerned, I think patients on ACE inhibitors can continue ACE inhibitors. But given this new ongoing pandemic, I would say starting out newly on an ACE inhibitor would be something that we would want to shy away from for the time being.
Right,
So patients who are already well tolerated on ACE inhibitors, I think they should not be stopped.
right. Now, as far as the hypertensive obese patients, as
Yes, sir.
in some of the slide, I mean, in one slide you have mentioned about the obesity. Any, your strategy in hypertensive obese patient, diabetic or non-diabetic, would be different from a normal BMI patient to take
Uh,
care of obesity and hypertension together.
I generally tend to evaluate these patients very strictly for OSA, obstructive sleep apnea, and we always do the polysomnography test. And if there is significant OSA, they need to be treated for OSA, because we need to understand that if the OSA goes untreated, despite the best drugs we get, we will not be able to get adequate BP control, and it further will actually increase the propensity of things like atrial fibrillation and stroke, which are very deadly, and it's actually going to add to the pill burden of this patient later on. So early on weight reduction therapy as well as OSA needs to be treated in patients who are obese.
So in COVID, obesity, they have higher mortality, and
Yes, sir.
hypertension, are the two things which put them on the highest risk of having deaths because of the cardiovascular mortality. Why do you think the obesity and hypertension, they are more prone for mortality in COVID-19? I think it is deviating from the topic. I think obesity is basically, they're inflammatory and it's very difficult to put them on ventilation to make them prone, etc. The question is, how much time do one should wait from 2 to 3 drugs? In place of 3 drugs in a single pill, is BP control better with 2+1 strategy, 2 in the morning, 1 at night? That is the question. So actually, then the basic purpose of having this kind of discussion lost here once you go back to the 2+1. So whatever I was saying, if you go for 3, I mean all 3, A plus A plus A, class 1 drug, class A drug, from the very beginning of hypertension, as Ayan was repeatedly mentioning, and 3 drugs as a whole in one pill. If you're giving 1 in the morning, 1 in the 2 in the night, or 2 in the morning, 1 in the night, then the whole purpose of having FDC is lost. Sometimes, second question is, sometimes we found in the older age group, above 75, BP is 170 to 70. Yeah, that's a good question. I mean, we are talking about isolated systolic hypertension. I don't know the name of the doctor. High systolic BP and low diastolic BP. If you try to reduce systolic BP, diastolic BP becomes further low. Which triple drug combination, what should be done? Will it help for non-deeper early morning side? Okay, the question is, if you have isolated systolic hypertension, once you start treating systolic blood pressure, the diastolic blood pressure goes down, is it a point of concern? How do you treat it?
It is a point of concern. So I think because cardiac or coronary autoregulation is something that is hampered beyond 60-65 of diastolic. Beyond that, we don't want coronary autoregulation shouldn't be hampered in these kind of patients, because elderly patients are very prone for coronary artery disease and are likely to have baseline coronary artery disease. So in these kind of patients, I would again say a low dose calcium channel blocker and a diuretic is something that generally works. But of course, because of the hardened atherosclerotic arteries in these, which is basically the cause of the isolated systolic hypertension, it is sometimes masked because of the hard thickened arteries of these kind of patients. So I would say that we should probably have a higher threshold for elderly patients, maybe not target lower thresholds like 130 systolic and 120 systolic. I would say patients who are more than 70-75 systolic of 150 should be acceptable.
Right. If your elderly is dipping, I mean, there is dipping of diastolic blood pressure, please look for their anemia, look for their aortic stenosis and aortic regurgitation, which can develop due to aging and atherosclerosis, or maybe he's leaking blood in the gut or in the urine because of the cancer. Those are the things should be excluded. Something like is there any concern of hyperuricemia in CKD patients with this FDC?
So I think chlorthalidone is responsible for some amount of hyperuricemia, but generally it is not very alarming. But anyways, most CKD patients are put on diets which result in low uric acid levels. But even if there is a concern, we should check, and they should be getting drugs like either allopurinol or febuxostat to control that. I mean, that is not a reason not to give these drugs to these patients.
Okay, so SGLO2 again reduces their uric acid if somebody is diabetic. And use of moxinidine as fourth drug. I don't think people still use moxinidine. Anyway, what's your thought on moxinidine?
So CKD patients, they use.
They use.
It is like clonidine, sir. Arcamin and Mothor.
Okay.
A lot of patients.
Risk of hyponatremia with long-term use of diuretic in the elderly. Yeah, it is still there.
Yes, sir.
It is in an younger pre-diabetic obese patient. Is CTD a better option than amlodipine in primary hypertension, where there is evidence of family CV attacks? So what he is asking, can he go with CTD alone rather than amlodipine if he has a family history of cardiovascular mortality?
So isolated CTD in younger patients have a very, difficult complication. It results in a lot of erectile dysfunction. So, and especially in diabetics also, it is a major issue. So I would suggest these patients should still get a standard dose of ACE inhibitor or an ARB, because it takes care of a lot of other things. It takes care of remodeling within the heart. It's renoprotective as far as diabetes is concerned. So I would say for a young diabetic, he should still be put on either a good dose of ACE or an ARB, whichever he's more comfortable with.
Yeah, I fully agree. Especially young hypertensive, they respond very well with ARB, small dose of ARBs and small dose of ACE inhibitor. But in elderly, I have a reservation against using this drug because of obvious reasons of hyperkalemia, and the response rate, BP reduction may not be that good as compared to hydrochlorothiazide or chlorthalidone, or diuretic acid, or indapamide, or amlodipine.
Yes,
so definitely, as Ayan has mentioned, young patients, and if you are treating young pregnant, I mean those who are contemplating pregnancy, perhaps these are the only group of people where you cannot use either of these. You should use beta blocker and preferably labetalol. And barring those expecting mothers, you can use these combinations. I don't see any other question here. So if you have any final thoughts on, like if I summarize, then it is affordable, easily available, and already the concept is there in the country as well as on the global perspective. Now there are a lot of new theories are coming up as far as the hypertension is concerned. And during this COVID situation, you must have seen that people are not coming to doctors, to Ayan, for their hypertensive crisis or accelerated hypertension, even ACAs or STEMI. So in one way, either they are not scared of coming to the hospital because of COVID situations, in spite of having stroke-like situations or hypertensive crisis or a heart failure, so they are managing home, or there is less incidence of these acute cardiovascular scare. Either the pollution, which has a good epigenetic mechanism, the stress, people are less stressed, they're sitting at home, maybe doing some physical exercise, they're not in the rat race. But in COVID situation all over the world, there are a few things which have very unique situation. Like most of these people in the US, I found, they start with headache, with fever, then they lose their smell and they lose their taste because of this AC2 inhibitor in the tongue, in the nasal mucosa. And those people who are hypertensive, they have the highest risk. And in Wuhan population, they have hypertension in 90% of cases, next the diabetes, next the obesity. There was a sudden increase in stroke in young because of thrombotic risk. There is sudden increase in around 32% of patients in Italy of DVT, VTE, pulmonary embolism. So basically, COVID is a kind of prothrombotic kind of situations. And if you have a D-dimer, which is high, ProBNP is high, you can have normal coronaries with thrombotic occlusions. Now, the standard therapy for hypertensive ST elevation MI is the thrombolytic therapy in many countries. The problem is, once you give thrombolysis, and if he does not respond to your thrombolysis, if he gets a recurrent angina, if you have cardiogenic shock, ultimately you have to take them up for the angioplasty. And things become messy because these thrombolytics and these COVID-19, they directly invade the myocardium and they can produce myocardial edema, myocardial inflammations. They are already prone for myocarditis-like thing. It becomes messy. So it is a difficult situation to treat them. But as Ayan has rightly mentioned that there are newer therapies will be available. You have to wait for the data like carotid baroreceptor stimulation. There is a pacemaker which can control the AV interval, can change the RR interval. This is called backbeat hypertensive therapy. Still class 3 for device therapy. RDN, you have to wait for RDN. This is radio frequency. We have alcohol injections. We have ultrasound RDN. And RDN will be available next month once the lockdown is over. So we have to hope for newer therapies. We have to embrace newer technology, newer combination, newer thought process. And everybody knows hypertension, and nobody has stopped talking about hypertension in the last 70 years, because we love hypertension because most of the people in India, the primary risk factor for developing atherosclerotic cardiovascular disease or heart failure or hypertensive heart disease is hypertension. Next is diabetes and obesity. So each and every physician should know how to treat hypertension, you should know how best to use the newer drug in which combinations. Don't go by always in the guideline. If you think that drug is a kind of personal medicine or personifications or personalized shared decision making, talk to the patient. If somebody develops a cough or somebody develops hypertension with some drug or possible hypertension, amlodipine or leg edema with amlodipine, you can always go for other combination drugs like ARB plus hydrochlorothiazide, CGGT like molecule. You can use SGLT2 inhibitors, the hypertensive heart failure, you can use beta blocker. You have a scope for clonidine, you have a scope for moxidine, you have a scope for hydrolyzine also, you have a scope for nitrates, you have a scope for Viagra for resistant hypertension. So there are a lot of drugs are available. There are epigenetic therapies are available. So there is still hypertension is a very beautiful subject. It's not a boring subject. I mean, like your cardiologist doing angioplasty. For us, doing angioplasty it's a mechanical job. But going into the depth of hypertension, and you think about the population you are treating. The next thing is happening is the aging population. It's a big opportunity for the doctors, young physicians. Now I'll divide the whole earth on 3 groups. One group is called super aged society, where the WHO says the population of more than 65 year age is above 21% of the total population. They are called super aged society, like Japan, like Italy. Then is aging society, like 14% to 21%, that bracket is aging society. We are in the less than 14%. Anyway, so these super aged society, they have more hypertension, more elderly people. The people are living longer. There are a lot of opportunities to treat these patients and save medicine, and effectually you can reduce the stroke, as Ayan was repeatedly mentioning. That is the most beautiful thing we can reduce. And if I ask to die, not to die in 3 diseases, I will ask, I will never want to die in stroke. I never want to die in cancer. I never want to die in CKD dialysis. Give me heart attack, heart failure, because it's so devastating. And treating hypertension, 10 millimeter reduction of blood pressure, gives tremendous amount of stroke reducing power. And all these drugs are safe. So if you do not have any further question, I would ask Ayan to summarize and the last comment from him, then we close. Yeah. Ayan, please.
I have nothing to add, sir. I mean, you've probably covered all the necessary things that needed to be said. And I think I would again reassure and tell everybody the same thing, that COVID-19 is something that is not going to go away tomorrow or maybe in the next year or two. So we as a species will learn to have to live with it. We'll have to adapt to the ways of COVID. And I think hypertension will still have to be dealt like we dealt with it before. And I think for physicians, it's important that you learn how to, get used to teleconsultations, web consultations, address patients, ask them to buy home monitoring devices. It makes our job marginally easier when we are doing web medicine consults. I think the admin can take over for last comments.
Just a minute. There are two more questions. I think more questions.
I think somebody wanted to know what was our take on indapamide, if I'm not wrong.
Yeah. I will take it over. Just take up the question. I can't read it. It's so small font of the letter.
So indapamide is also something that works very well in elderly hypertension. If you want to low dose indapamide, it basically circumvents the issues with dyselectrolytemias that is more common with CTD, and it takes care of essential hypertension in the elderly. So isolated systolic hypertension, I would suggest that indapamide is not a bad drug to start with. But although I think it is not very effective in gross hypertensives.
But deeper and non-deeper, any comment on it will be very useful in preventing morning surge?
I don't have data on that, but I understand that because of the better control of blood pressure generally with these 3 molecules, I will guess that it will take care of the dippers and non-dippers also. So overall, it should reduce stroke rates. So which in turn does mean that your dipper and non-dippers are taken care of also.
I think we have covered almost everything. I'll wait for 5 more minutes if there is any question. Otherwise, I'll hand over the session to our admin. And Dr. Momin, can you hear me? Akhil?
Yeah, sir, we are there.
Yes, sir.
Yes, sir.
I think we have done from whatever is possible from our side.
Okay.
And you can ask your doctor or other people to have a direct conversation. Now they will talk and we'll listen.
Right, sir. Thank you so much, sir. Thanks a lot for a wonderful session, sir. It was very interesting. And Dr. P.KHazra, sir, has really made it very, very interesting. Sir has moderated the topic. I am also thankful to Dr. Ayan, sir, for a wonderful presentation. It's a real indeed our pleasure and privilege to have both of you, sir. And I'm sure the topic of triple drug hypertension, triple drug combination in hypertension in today's scenario was very interesting, and all the viewers liked it. And I think with Ayan sir's permission, I think the slides, if required, can be shared with the audience if somebody asks for it.
Most welcome. You're most welcome to do that.
Thank you so much, sir. Because we get a lot of queries. Can you share the slides with us? And with your permission, sir, again, it will be honor for us that we can share this information to our viewers. So thanks a lot. Yes, sir. Yes, sir. Yeah. So thank you so much.
Okay. See you. Take care.
Yeah. See you. Thank you, sir. Bye. Bye.